So the first question is what might be the biomarkers, and there I think we'll start with what have been proposed as biomarkers for each of the classes of therapy independently. So for aurora inhibition, people have looked at RB, they've looked at MYC, and for WEE1, they've looked at cyclin E1. So what we find is actually that the aurora inhibition induces cyclin E, and so if you're giving the combination, we don't believe that you'll need cyclin E at baseline as a biomarker because you'll be able to induce it with the aurora inhibition. And in fact, we think the P53 mutation is going to prove to be a very important biomarker. And so the proposed trial that's moving forward through Combo Match looks at P53 mutation as the biomarker of highest interest. I do think it's feasible to use biomarkers to select patients for treatment, both in clinical trials and in clinical practice. We routinely are using HPV for clinical trials accrual. I think many people are making definitive therapy treatment decisions based on HPV. Most people are probably not using EGFR inhibitors as a primary therapy for HPV-associated cancer, although it's quite interesting that petosemtamab, in distinction to the other two EGFR bispecifics, does seem to be active in HPV-associated. And for many of the ADCs, so we're now testing for, HER2 because there's a disease agnostic indication for that. We're looking at TMB, we're looking at PD-L1. I think for HPV-associated cancers in the ADC space, it looks like Nectin-4 and tissue factor might be interesting. There's a MET antibody-derived conjugate that I expect will be moving forward in head and neck cancer. So I think increasingly we are going to be needing biomarkers to make treatment decisions in the recurrent metastatic setting. For resectable patients, PD-L1 testing is required to decide if you're going to give neoadjuvant pembrolizumab. So I think that people are increasingly comfortable with that. And in fact, we're getting genome profiling on all of these patients now as well. So I don't think that's going to be a feasibility issue at all. And head and neck cancers may be a little bit behind. I mean, in lung cancer and colon cancer and prostate cancer and breast cancer, all of these tests have been routine for a long time.